Welcome everyone for more one Global Stroke Alliance. It's a great pleasure to have all these speakers and moderators here to talk about this very interesting, important topic that is PFO. Despite the latest evidence related to stroke and PFO, there are still uncertainties. Which stroke was actually caused by PFO and how to evaluate this patient, what's the best treatment, aspirin, anticoagulation, PFO closure. So tonight we will know about this. And let's start with a question to the audience. Let me see here. Male, 40 years old, without risk factors, has a cortical. Could you send the questions? Pode enviar a primeira pergunta? Pode enviar a primeira pergunta, sim. Male, 40 years old, without risk factors, has a cortical MCA stroke. In the investigation, a PFO with a large right to left shunt plus aneurysm de septo interatrial. No other possible cause was found. What's your choice of treatment? Aspirin, anticoagulation, or PFO closure? Let's vote. You can see the questions in the audience. Please answer to me. In the chat, you can answer. So the results, 10% aspirin, 10% anticoagulation, and 80% PFO closure. Let's see the second question to the audience. Male, 40 years old, without risk factor, has a lacunar stroke. And in the investigation, we found a PFO with large right to left shunt. No other possible cause was found, but now they have the person has a lacunar stroke. What's your choice of treatment? Aspirin, anticoagulation, or PFO closure? Let's vote. Well, 10% aspirin, 13% anticoagulation, and 75% PFO closure. So the last question before we start, let's put the last question. A male, 65 years old, without risk factors, has a cortical MCA, middle cerebral artery stroke. In the investigation, a PFO with a large right to left shunt. No other possible cause was found. What's your choice of treatment? Aspirin, anticoagulation, or PFO closure? Let's see. Let's see the answers. So 33% aspirin, 12% anticoagulation, and 50% PFO closure. Well, Luciano, I think you and Dr. Pedra has a long way to go in tonight to teach us about this. So I'd like to introduce you, Luciano Esposato from Canada, Western University, to talk about diagnosis, major trials, and considerations in elderly population, the neurology perspective. Luciano?
Thank you very much, Sheila. It's a pleasure to be here sharing this academic activity. Good night, everybody. Thanks for the invitation. And I hope we can interact a lot in this during the whole night. So I'm going to try to share my screen. Let's see. Okay, here we are. Perfect. Okay, so I'm a neurologist, a vascular neurologist, and in our lab we investigate the relationship between the brain and the heart, and that's why my interest is in PFO among other topics. These are my disclosures. And this is the agenda for today. So we're going to talk very briefly about the epidemiology of PFO and stroke. I'm going to tell you what we do and what the evidence is about screening and diagnosis of PFO in stroke patients. I'm going to try to summarize the most important findings of the randomized controlled trials about closure and medical treatment. And then I'm going to briefly touch PFO closure in the elderly population because that's an open question. And finally, we'll try to identify what the knowledge gaps are and what the future directions should be in terms of research about this topic. So in terms of the relationship between PFO and stroke, we know that there are about 17 million strokes per year around the world. And we think that around 1 to 3 million of those strokes can be caused by PFOs. So it's not that it's a minor thing. It's a really important cause of stroke that it's largely undertreated around the world, and that's one of the things that we're going to see tonight. Sorry. So in terms of screening and diagnosis, you must be very familiar with the ROPE score, which is used mainly to identify whether strokes are likely caused by PFOs. So the score includes hypertension, diabetes, stroke or TIA, smoking, whether the stroke is cortical, and age. And I don't know what you think about this, but very honestly, I'm not a very big fan of the ROPE score because I think it has kind of circular logic in which just by the fact of not having hypertension or diabetes, because they are related to small vessel disease, and that would mean that someone does not have a PFO related stroke. And the other thing is that it relies too much on age. And I'll show you an example here. This is from the MedCalc page. And as you can see here, we have here on the left side a patient with no history of hypertension, no diabetes, no history he did have a stroke previously, no non-smoker, and he has a cortical infarct with an age of 30 years old. And then we have exactly the same patient with an age of 70. So just because of the age, you can see here that the chance of that patient of having a stroke caused by a PFO is 72%. If he's 40 years older, it means that it's 0. So this has a very huge weight on age, and that's the thing that I don't like about this score. And this is something that we can leave for further discussion at the end of the talk or in the Q&A part. So what can we do to identify those patients who really have strokes caused by PFOs? Well, we have something that we need to know is that we usually investigate patients who are older than 60 or 60 years old. And the main reason is that most of the clinical trials have been done in that population. So even if we find someone who has more than 60 or 65 years with a PFO, the decision about closing that PFO, it's quite challenging. And for that reason, we try to save the resources for those patients who are more likely to receive a closure. There are two things that are important, and then they might be related to the second question that you had to answer today earlier. And the most important part is that there is no relationship between any topographic lesions and the PFO as the cause of a stroke. So it means that PFOs can cause strokes in any vascular territory or cortical, subcortical, or even deep structures. And the other thing is that non-cortical infarcts, and this is related to the previous concept, can still be caused by PFOs. So the fact that they are not located within the cortical regions doesn't mean that those PFOs were not the cause of the strokes. And that's something very important, and it's also related to the ROPE score, which gives points for cortical strokes, but not for deep ones. So we have to be very careful on about how we name those strokes. If we say that they are lacunar strokes, we might be implying that the mechanism is different from an embolic mechanism. So we should probably try to describe the lesion, and that's it. So other features that that may be helpful for deciding whether someone who's older than 65 did have a PFO related stroke is the presence of pulmonary embolism or DVT, or deep vein thrombosis. If patients trained just before the stroke, for example, if they bent over to pick up something from the floor, or if they were picking up something heavy, or if they were just having a bowel movement. So those are contextual things that are important to ask for two patients who have embolic strokes, who are older than 65 and who do not have any other mechanisms. And another important concept is that those patients who have strokes during sleep or wake-up strokes have a higher chance of having PFO-related strokes. This should be considered with caution because AFib-related strokes usually tend to happen overnight, and then if these are older patients, they may still have a PFO or a paroxysmal AFib that was not diagnosed. Okay, so given the difficulties there, it might be interesting to look at the paper by Elgendy in JAMA Neurology this year, which classified patients into high, medium, and low risk. Basically, they base the classification on the size of the PFO and the presence of an atrial septal aneurysm, which we know that it's associated with a higher risk of stroke. And you can see on the right side of the screen how it relates to the ROPE score. And I really recommend reading this paper because it's a nice paper. So once we have selected those patients that may have a PFO-related stroke, we need to decide how we're going to investigate them. And we need to know what the sensitivity and specificity of those of available tests are. And you can see here that both TCD and TEE, or I'm sorry, TTE, or transthoracic echocardiogram, have a very good AUC, or also a very good sensitivity, as you can see here. This is compared to the TEE, which is a gold standard for those tests. But then when we compare the TEE against autopsy, surgery, or any procedure done through the PFO, you can see that the TEE has a very good AUC and a very good sensitivity as well. So most of the studies, if they are done by good operators, they have a very good sensitivity and can be used interchangeably. So you can see here, this is a very interesting position paper by the European Heart Society, in which they recommend using TTE or transcranial Doppler as the first approach. If any of them is negative, then we can use the other one. For example, if we have a patient with a high suspicion of PFO, in which the TEE or the TTE is negative, then we can go and do a transcranial Doppler. And if that's negative, then we can assume or conclude that the patient does not have a PFO. But if any of them is positive, then we should probably do a TEE to really document the size and other features of the PFO or the right atrium that might be important in the decision-making process. So that's a very simple algorithm that I really like, and that's what we do here in Western. So what should we look at in the TEE? We should look at the features that may increase the risk or the likelihood of a PFO being the cause of a stroke or TIA. So we know that the presence of an aneurysmal atrial septum is related to a higher risk of PFO-related strokes. Of course, the size of the PFO is something important. We need to know that it's not so easy to document the size of the PFO. It has some complexity and it's not measured everywhere. But whenever it can be measured, it is important to document the number of bubbles. Usually over the number of 20 or 25, we consider that at least it's moderate to severe, and that patient might be a good candidate for closure. The other features that we need to look at, which are not so common, are the Chiari network and the eustachian valve, which are embryologic remnants that we can see in the right atrium. And the main reason that we should probably pay attention to them is that the eustachian valve, as you can see, directs the bloodshed to the PFO. And when it's present, it's more likely to send clots that comes from the inferior vena cava, most likely the inferior one, to the PFO. And then the other structure, which is a Chiari network, it's a kind of net that can favor the production of clots, and it's important to know whether it's there. Here you have an example of a Chiari network, and here you can see the presence of a clot within the network. So what do we know from clinical trials? And basically we have at least 6 very well conducted randomized clinical trials, but you can see that the evidence that today we have about PFO closure versus medical treatment is really a lot compared to what it was a few years ago. So the evidence is much more robust in terms of what recommendations we can make for treating these patients. Basically, we have the closure 1, the PC, respect, close, GORE, and defense PFO trials. I'm not going to go into detail because we don't have time, but I'll try to summarize the main results in terms of meta-analysis, and that should be, I guess it should be enough. Overall, we know that when we consider all the trials together, there is a 60% reduction in the risk of recurrent strokes, as you can see here in this chart. There's no change in terms of major bleeds or deaths, but there is a quite substantial increase in the risk of incident atrial fibrillation. And I'm going to touch that topic a little bit later, but we need to know that the risk of finding a new AFib, it's 5 times higher in patients receiving a PFO closure than among those receiving medical treatment. If we look at the risk of ischemic stroke and the benefit of PFO closure related to the size of the PFO, we have here low-risk patients in the first chart, which shows that there might be a 20% reduction based on the major clinical trials, but this is non-significant. When we look at high risk, we see that there is almost a 70% reduction, 65% reduction in the risk of recurrent stroke. And when we consider all together, there is around 55% reduction, mainly based on the high risk profile. But if we look at data from the reduced GORE trial, which is the one that included more patients with small PFOs. As you can see here, 77 patients with small PFOs. There was no significant interaction between in terms of the size of the PFO. So I would just leave that as a question. We really don't know how important the size of the PFO is. Of course, it is important, but the main conclusion is that it might still be beneficial to close the PFO in those patients. The difference might be that the number needed to treat is much higher than for patients with moderate to large PFOs. What happens with atrial fibrillation? I told you that the risk is about 5 times higher, depending on the meta-analysis. It might be 4 times higher, as you can see here in another meta-analysis. But most of that risk is driven by the first 45 days, as you can see here, with 5-fold increase within the first 45 days. But then after the first 45 days, there seems to be a marginally significant risk, but it's much lower than within the first period. So what this is telling us that if someone survives the first 45 days without AFib, then the risk of developing a new AFib is much, much lower. And usually those paroxysms of atrial fibrillation are self-limited or respond very well to cardioversion. So to summarize what the characteristics of post-PFO closure AFib are, I said that there is a 5-fold increase in the risk of incident AFib. Most of them are transient and revert with the usual treatments. It is much more common in the first 45 days. And most importantly, only 0.1% of those AFibs are related to strokes, are deemed to be the cause of a new stroke or a recurrent stroke, which is, as you know, a very, very low proportion. And we never know if it's just the AFib or another mechanism. An interesting study here is that, and this is one of the hypotheses about why patients with PFO closure have more AFib. And it is possible that patients with PFO have a higher incidence of AFib just because of the PFO or an aneurysmal atrial septum. So this is a nice study in which they looked at the TEE of patients who were going to have a pulmonary vein isolation. And when they did the TEE, they found a PFO in only 18% of those patients. But then when they went to do the procedure, they found that there was a 57% prevalence of PFO in those patients during the procedure, which means that there might be an underdiagnosis of PFO among patients with AFib, and that AFib might be quite common in patients with PFO. And then this is an interesting comparison that I always like to make. And if you look at patients with that were enrolled in the migraine trials, and you compare the risk of AFib in the meta-analysis of all those trials, it is non-significant. It's around 3.5 with a non-significant confidence interval. But when you look at the same data in randomized controlled trials of stroke prevention, then the risk is as high as I showed you before, and this meta-analysis is around 5% as well. What I'm trying to say with this is that maybe in some of these patients that are sent for closure or that they are considered as good candidates for a PFO closure because of the PFO, the AFib might be a competing risk that is not diagnosed until the PFO is closed. So we really need to be sure that when we send someone for closure, that patient does not have an AFib. And the best way of looking at AFib is by doing very prolonged cardiac monitoring. So what happens with medical treatment, anticoagulants versus antiplatelet therapy? This is a meta-analysis of whatever has been published until 2019. It includes randomized controlled trials, observational comparisons, non-randomized comparisons. And you can see here that there is about a 12% risk reduction with anticoagulants compared to antiplatelets. But I would say that the evidence that we have about this is very poor. I mean, it's poor quality, as you can see, based on the types of trials that have been included. And I would leave that as an open question. We really don't know how much anticoagulants prevent recurrent strokes in patients with PFO, and we actually need a randomized controlled trial for this. Okay, so what happens with the elderly population? And I'm going to try to be brief here. Basically, we know that 35% of patients, of elderly patients with cryptogenic strokes have a PFO, and that's about the same proportion of PFO prevalence that younger patients of the overall population of stroke patients have. And most interestingly, 36% of those PFOs are large enough to cause a stroke. So And if you look at those numbers, they are quite similar to those of the overall population with stroke. So what does this mean? It means that PFOs are common in people over the age of 65 years who have cryptogenic strokes. And those PFOs are quite large and similarly large as those of the general population. The other interesting aspect is that if you look at the right side of your screen in figure 2, you can see that the risk of having a recurrent stroke in patients with PFO increases with age, and that's expected because those patients have more PFO, more hypertension or other risk factors, and they tend to develop AFib while they age. But interestingly, when you compare patients who are younger than 60 or older than 60, you can see that the ones who are older than 60 who have a PFO have a much higher risk than those who are younger than 60 if the PFO is not closed. So if we know that the PFO by itself increases the risk of recurrent strokes in people over the age of 60, there is equipoise for really conducting a clinical trial in people over the age of 65. So of course, we don't have clinical trials yet, but we do have observational data as these results from the Quebec Heart and Lung Institute in Canada. And you can see here, there are 90 patients over the age of 60 versus 385 who are younger than 50, followed for a median of 8 years. And there were no significant differences here. Of course, the number of patients is very low, as you can compare with the clinical trials. But there is a red flag here, and it is the increased risk of those patients. Of course, the 5-fold increased risk that you can see here in the table might not be related to strokes themselves, but just cancer or other comorbidities that these patients have because they are just older. In terms of the guidelines, the new American Academy of Neurology guidelines suggest that people over the age of 60 or 65 could be considered for PFO closure, and this is level of evidence C if there are no other competing causes. The European position statement suggests that for patients over the age of 65 who do not have any other competing risk, PFO closure may be considered, but they do recommend implantable cardiac monitors for at least 6 months before indicating PFO closure in this age group. So which are the knowledge gaps that we have identified? In first place, we know that there will be lots of PFO, or the number of procedures will be increasing steadily within the next few years, and we will not know what to do with the elderly population. We don't know if there are any sex differences in terms of the benefit of PFO closures. I do suspect that there is a huge gap in terms of access to PFO closure throughout the world. If you look at different regions of the world, the access to PFO closure might be quite dissimilar. And we don't know really what the impact of atrial fibrillation after PFO closure is. We don't know if it's a pre-existing condition, if it's caused by the PFO closure, how is it caused by the PFO closure, and if it really has any relevant clinical implications. With the hope to respond to some of these questions, we are conducting the IMPROVE registry, which is a global registry of PFO and stroke. So far, we have enrolled over 1,000 patients in lots of countries, as you can see there. And Brazil is becoming part of the registry, and we hope that lots of centers will be part of it. And we invite everyone to talk with Dr. Sheila Martins and Octavio Pontes Neto to be part of this study. Well, thank you very much for your time, and I'm open to questions when the time comes. Thanks.
Wonderful, Luciano. Thank you for a great presentation. Wonderful. Now Let's see the cardiologist perspective. Dr. Carlos Pedra from Nagacor and Dante Pazanese has a large experience with PFO, and he will talk about classical indications, technical aspects, and special indications. Dr. Pedra.
Thank you, Sheila. It's really a pleasure to be here among neurologists, and I was thrilled with Dr. Sposato presentation. I think I'm going to invite him to go some PFOs because I loved him talking about, Chiari network and eustachian valves. It's very unusual to see neurologists talking about these things, and of course he has to put up with me teasing him because Brazil is way better than Argentina playing soccer, right? So that's my task. Let me share my screen here. And I'm going to talk about the cardiologist perspective. I'm going to touch on some special indications that might sound a little weird for the neurologist. I'm a proctor for the Amplatzer devices. I'm also proctor for the Melody valve. But my main conflict of interest here is that I have a PFO. So I'm very laid back when it comes to talking about PFO, which is found in about 25% of the population. And PFO per se is not a risk factor for having a stroke, right? If you compare population with PFO and without PFO, the risk of having a stroke is about the same. There are at least 3 large studies with longitudinal cohorts of patients addressing this issue. However, if you compare patients with cryptogenic stroke and patients with known cause of stroke, the PFO is much more prevalent, not only in patients younger than 55 years, but also in patients over that age. There was a paper published in the New England, especially in patients with aneurysm of the interatrial septum. What about predictors of a pathogenic PFO? Of course, those patients usually do not have those conventional risk factors for cardiovascular disease. These are young patients. Sometimes they have immobility periods such as long trips, or they are lying in bed after surgical recovery. They might have deep venous thrombosis. Those events might be triggered by Valsalva maneuvers, or they occur when they wake up, especially in those patients that snore a lot due to sleeping apnea. We do rely on the ROPE score. It's not the best score, such as Dr. Sposato alluded to, but it's interesting. If you don't have many risk factors and if you are younger, it's more likely that the PFO is the culprit of that stroke. And this is a north, it's like a guideline that we rely on. And there are PFOs and PFOs, right? There are very high risk PFOs. When people say about, wow, what about the size of PFO? Well, it depends. I mean, PFO is not there's a rigid size. I mean, it varies with systole and diastole, especially when you have a very mobile interatrial septum or a aneurysmal septum. But when you do have right to left shunt at baseline, then this is a very high risk PFO, especially when you have an aneurysm, as you can see here, and with high conductance PFO, with lots of bobo passing through the PFO after injection in the peripheral vein. It should be regarded that, should be noted that it's better to inject those bubbles in the inferior limbs, especially when the patient has those Chiari networks, or a very prominent eustachian valve that works as a tray directing the flow through the PFO from the right atrium to the left atrium. And this is an example of a long eustachian valve. So this is a kind of higher risk PFO, and those tunnel PFOs, when there is superimposition of the lamina of the vasovalis on the septum segundum larger than 15 millimeters, they can be considered high-risk PFO. And sometimes some advocate that a thrombus can be formed in that region. And some authors have also advocated that some patients with very dilated ascending aorta and a horizontal heart lying in the chest can also be more prone to right to left shunt, and we do see this thing happening in some diseases. So this established knowledge, right? Association, a very strong association between cryptogenic stroke and PFO. And we should change the nomenclature, and we're gonna touch on that based on the Christian Principino paper, also addressed by Luciano. We should change to PFO-associated stroke. It's totally different. And what about the objectives of treatment? We have to prevent new strokes due to the high risk of recurrence. Which is the best secondary prophylaxis? Antiplatelets, anticoagulants, percutaneous. Of course, we eschew surgical closure. It should be regarded as class 3. And I'm gonna show some Kaplan-Meier curves. This is from the first trial presented at TCT, showing a clear benefit of closing the PFO with the device, leading to a 55 reduction risk based on intention to treat analysis. And the benefit is even higher when you have a substantial shunt, or if you have an aneurysm of the interatrial septum. The reduced trial sponsored by Gore show more or less the same curve here, and also the closed trial in France with a myriad of devices showing a superiority of PFO closure. Interestingly, this study has a third arm comparing anticoagulants and antiplatelet, and there was no difference between those strategies, although this study was not really powered to address that question. So we saw, like what Luciano said, that those patients can be prone to atrial fib. There was no difference in the RESPECT trial, and in the RESPECT trial, the Platzer device was used. There was a higher incidence in the reduced trial. In that trial, the cardioform device was used, and in the closed trial, there was a higher incidence as well with a myriad of devices. However, there was no clinical impact of the AFib in new events. They were all transient, all resolved within 6 to 8 weeks, and those patients are put on a short period of oral anticoagulants and then aspirin. So, I'm not sure about, this great deal about AFib, right? It doesn't seem that there is a clinical impact of this complication. I had the privilege to review that paper published by Christian. It is a Herculean task that those guys did, a very, very well written paper, and they used a very different methodology. It was great, and they answered some population intervention comparator outcomes questions, and they came up with statements like strong, conditional, and they also used the level of evidence. They put a lot of emphasis on ruling out atrial fib before embarking on PFO closure. So this is a very important topic, not only a 24-hour Holter monitoring, but also a looper at least a week, especially in patients on the older aspect of the spectrum. And they also proposed this new definition, PFO associated stroke. We have the courage, the guts to state that. This is very important. And we already addressed, all those risk factors, atrial aneurysm, hypermobility, moderate to severe shunts. All these factors are associated with the cause of the stroke. Not only that, but also a risk of recurrence. So that's why we have to consider all those anatomic factors when it comes to closure. This should be a shared decision-making. We have to talk to the patient, and the patient should accept the risk of closing the PFO. However, you're going to see the risk is very, very, very low. That's why some people are closing PFOs that should not be closed, unfortunately, and at least here in Brazil. And Christian came up with this very strong statement for the intervention. So in selected patients, young patients with cryptogenic stroke, closure is a better treatment than medication, whether it's aspirin or anticoagulants. And it was interesting that this was one of the first papers that touched the follow-up after closure. And I'm not going to go over all that, but we can touch in the discussion sections. And when it comes to technical aspects, I think even for me, I am an interventional cardiologist. This is a very boring topic because the procedure is very, very easy from the technical standpoint. It's so easy then that some people are closing PFOs that should not be closed. And this is very sad because this is, of course, malpractice. It's a very effective procedure and very, very safe with virtually zero incidence of severe complications. This is from the RESPECT trial with almost 500 patients submitted to PFO closure. There were no intraprocedural strokes, no embolization, no thrombosis, no device erosion, there was no difference in atrial fib, as already said. There was no major bleeding. The incidence of death of any cause was the same in both groups. However, there was a higher incidence of deep venous thrombosis in patients submitted to PFO closure, probably because those patients have some tendency, they are like thrombogenic. We don't know. These are not thrombophilias like protein C or protein S, depression, nothing like that, but maybe some higher regression of platelets. We really don't know. We think that the PFO is just a matrix, but those patients are probably more prone to micro thrombi formation, probably wide thrombus. We don't know yet. So if you ask me, PFO closure prevents new stroke, for sure, especially in young patients with a clear-cut clinical picture, evidence of stroke on imaging studies, TCD, I didn't touch that, but this is a very important topic, which is very sensitive to right-left shunting, showing a high conductance in those patients with somewhat like higher risk PFOs. And of course, those patients that fail to antiplatelets or anticoagulants, they also should be, those PFOs should be closed. So I'm gonna change gears here and talk about some alternative indications. This paper has not published as yet. It's under revision. In fact, it has been accepted already. I talked to Christian and he allowed me to show some data. And I'm talking about decompression syndrome and PFO. Decompression sickness is a very complex condition triggered by the trapping of gas emboli in vessels and tissues, and is caused by a subject moving from a higher pressure system to a lower pressure area, such as rapid ascent at very high altitudes or returning to sea level after an ascent from the depth. And the PFO can lead to paradoxical emboli and stroke. The problem here is that PFO is a very common condition, and decompression sickness is very, very uncommon. So the relation, the association between these two is somewhat tricky when you take a look at the literature. And this is very interesting. This is the paper from, again, Christian. And patients with PFO are more prone to have decompression sickness than those patients who do not have a PFO in this meta-analysis. And what's the approach, the medical approach to those patients who are divers or who are jet pilots? I'm not talking about commercial flights here. These are military flights, very, 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 very high altitudes with very low barometric pressures. We have to make sure that the patient did have a syndrome. We have to study the PFO. We have to assess the risk of recurrence. What about the habits of flights, of diving of these patients, and the probability of these patients have a new event? And again, to share the decision making with the patients and with the proper local societies. So this is a flow chart. The patient has a very suggestive clinical event. You have to evaluate the profile of this diver or pilot, and if it's a high risk, is this patient willing to change his habit? Okay, no. So let's move to PFO testing. And if you have a PFO and if the patient is not willing to change the habit and you are sure that this patient had decompression sickness clinical picture, you should consider PFO closure. And this is the statements here, all strong statements favoring the intervention for secondary prevention if the patient is not willing to change their habits. And what about primary closure? Because we know there are some professional divers, right? It's very unusual to bump into those military pilots, almost going to the outer space. It's very unusual. What we do see in clinical practice is like pro divers who cannot change their profession. They live on that profession, and of course they're not going to change their habits. And then we should consider closing the PFO to prevent the compression sickness and also some neurological events. And this again should be a shared decision. So I'm going to touch on migraine. This might be more interesting for the neurologist. Who am I to talk about migraine? I'm a mere cardiologist talking about migraine among neurologists. This is crazy, but it's a very common disease. It's chronic. It's a multifactorial disease, a very heterogeneous population. But interesting enough, migraine, and when it comes to the epidemiology of migraine and PFO, it's similar if you compare to cryptogenic stroke and PFO. And interesting enough, when you close PFO for patients who had a stroke, and those patients coincidentally who had migraine, the migraine really usually it improves. So it was an observation made in the early 2000s by an Irish neurologist. And what would be the cause of migraine and related to PFO? Probably some microthrombi or vasoactive chemicals cross the PFO and trigger a process in a susceptible matrix causing cortical depression. Very nice words. I don't understand that. This is all neurology. But anyways, And this paper conducted by Christian put a lot of emphasis on and you have to be to associate a special type of PFO and migraine, especially when you have ARIA. Those patients had a previous stroke. It's more likely that the PFO might have a role. And if the patient is older and there is small shunts through the PFO, it's less likely that the PFO is the culprit of the migraine. It's not the culprit because, of course, migraine is a multifactorial disease. And again, this is a flow chart to how to conduct those patients. Patients on maximal medical treatment with a refractory migraine, you should look for cerebral vascular disease. If there is no previous stroke, you should make sure these patients have ARIA. And if they do, you can look for a PFO and consider a PFO closure in these rare patients with refractory migraine. Does PFO closure improve migraine? Well, most of trials were observational, single arm trials. There were like 3 trials, randomized trials, but those randomized trials had very rigid endpoints. Migraine get better or not, and this doesn't happen in clinical practice in life. You have to be more flexible. I think when you're dealing with migraine, you have to ask your patient, do you get better in terms of intensity of your headache, in terms of frequency? Are you going to work more often? These are important questions. And interestingly enough, those patients with and without ARIA, they behave the same way. It seems that they get better with PFO closure. However, the type of statement made in that paper was a conditional statement against the intervention. Why? Because we do not have enough data to support routine closure of the PFO in patients in migraine. However, in some individual patients, after an extensive workup and with refractory migraine, you might consider PFO closure. And again, this is a PICO question. Should percutaneous closure of PFO plus medical therapy versus medical therapy alone be used for reducing migraine? So that paper came up with, after lots of evaluations and balancing the effects of both kinds of treatment, probably PFO closure can result in an improvement of migraine in a very selected patients with ARIA or cerebral vascular disease. There is a word of caution here. Due to uncertainty of results, we should come up with more studies to confirm this find. So this is an area for future research to identify subgroups that are more prone to a PFO-associated migraine. There might be some phenotypes, some patients who are responders to some specific antiplatelets agents. Bob Surmer in the US is leading a very large trial in this regard. Hopefully we can have the results soon. And of course, these patients should have some high conductance PFO. So I'm gonna talk about some crazy things. It's good that neurologists, all the neurologists could, have an idea of those deoxygenation syndromes. This is more common in cardiology than in neurology. There are some patients with platpenia, orthodeoxia syndrome. This is a very strange name, but basically those patients, when they come from a lying position to the sitting position or the standing position, they desaturate. Usually those patients have some sort of surgery, thoracic surgery, pericardiotomy, some kind of tumor, lung tumor. Sometimes the heart is horizontal. So this is that syndrome. Other syndromes such as OSA, exercise saturation, chronic pulmonary obstructive disease, and how adds to pulmonary edema. And PFO closure in such patients, especially patients with platypnea, obstructive sleeping apnea, and exercise saturation, they get better when you close the PFO. But this is based on observational studies that, and I, you know, there won't be any randomized trial because these are very, very rare patients. So you should consider PFO closure in those patients. And what about PFO and prevention of surgical thromboembolism? With regards of pregnancy, delivery, and puerperion, PFO screening is not required, not recommended, at least in this paper, not recommended either in patients under evaluation of non-cardiac disease. However, this is important for you guys in neurology, in patients who are going to undergo neurosurgery in the sitting position. PFO screening is mandatory, because if you get, you know, air bubbles in the vein, and sometimes the anesthesiologist is not careful enough, those bubbles can cross the PFO, go to the brain, and cause damage. However, PFO closure should not routinely advise it in such patients. So in conclusion, PFO closure should be regarded as the first-line therapy in patients with PFO-associated stroke. PFO closure should be considered in selected patients with decompression sickness, both primary and secondary prevention, and also in patients with migraine refractory to conventional treatment. And PFO closure should be considered in patients with those uncommon and selected syndromes of desaturation. And with that, I conclude, and thank you for your attention, and I'm open for questions. Thank you, Sheila.
Wonderful lecture, Dr. Pedra, wonderful. Let's start with a case first and open to discussion after. So I'd like to introduce João Luiz Mânica. He's a cardiologist, interventionalist from Moinhos de Vento in Instituto de Cardiologia. And Mânica will talk about a case presentation, PFO and decompression illness. Mânica?
Thank you, Sheila, for your invitation. I will present, let's do it, okay. I will present a very interesting case of patent foraminal valley and its relationship with decompression sickness. Our patient is a 32-year-old female. She is a technical diver. Technical diver is a category beyond recreational diver, requiring long experience, knowledge of stage decompression techniques, the use of different gas mixtures, and extensive equipment and technology. In 2017, she went to Federated States of Micronesia for a diving trip, as she usually did annually. On November 20th, 2017, on her dive number 161 and 162 in her whole life at Truk Lagoon. Truk Lagoon is a Second World War Japanese naval base with a lot of shipwrecks. She reached around 28 meters, which is around 10 feet deep, very well documented on her logbook and with all protective maneuvers. And approximately 60 minutes after diving, she developed a mild cutaneous rash, which was self-limited, and she decided to keep diving normally. It's not uncommon among divers to underestimate this condition because it's a self-limited course. So after 7 days, she continued diving, and on her diving number 174 and 175 at the same place, She dived deeper. She reached around 60 meters deep, which is around 20 feet deep. She did all protective maneuvers. She used gas mixtures containing less nitrogen. She did adequate surfacing interval between both dives. She did not perform rapid ascent, but and all of these were very well registered on her logbook. And again, approximately 60 minutes after diving, she developed a more severe cutaneous rash and then was diagnosed with cutis marmorata, with its typical geographic appearance of the lesions around sides of the trunk and buttocks. She was diagnosed what they call as an undeserved decompression sickness because it happened despite all protective maneuvers. It was not a provocative dive. She was not referred to hyperbaric chamber due to the absence of neurological symptoms, but it was suggested to her to stop diving. So she went back to Brazil and she was immediately sent to a transesophageal echocardiogram that detected tunnel-shaped patent foraminal valley with at least moderate shunt from the right to the left side. You can see a lot of bubbles reaching the aorta. And the question from the neurologist and the cardiologist was to close or not to close these defects. So just a very short review. Decompression illness comprises two similar phenomena with two different pathophysiology. Arterial gas embolism is a life-threatening situation. It occurs directly after surfacing, very associated to provocative dive, and occurs due to pulmonary overinflation syndrome or previous lung disease. Venous gas embolism or decompression sickness, that is the scope of our presentation, occurs by the presence of nitrogen venous bubbles that reach arterial circulation due to right-left shunt or overwhelmed lungs. It can be mild if associated to local symptoms or severe if associated to systemic symptoms. Cutis marmorata was historically classified as a type 1 decompression sickness or a mild decompression sickness. But recent literature demonstrated that cutis marmorata is not caused by local bubbles phenomenon. Actually, it is a form of spinal cord decompression sickness and is highly associated to PFO and may be a precursor of more severe decompression sickness syndromes. The risk of Dr. Pedra already talked about it. The risk of decompression illness is 5 times higher in divers with a PFO, and MRI studies detected ischemic brain lesions as twice as high in experienced divers with a PFO. If bends occurs after dives that were not provocative, commonly referred as undeserved decompression illness, or have a tendency to recur, percutaneous closure of PFO should be considered to eliminate the probable precipitating factor. So can I dive with a PFO? The last guideline published in the literature is 2015 from United Kingdom Sports Diving Medical Committee. The statement number 2, consider PFO investigation in patients with history of decompression illness with cerebral, spinal, vestibular, or cutaneous manifestation. In patients with history of cryptogenic stroke or migraine with aura, it's interesting that they relate migraine with aura, and in patients with history of PFO or ASD in a first-degree relative. And the statement number 5, consider for patients with PFO really associated to increased risk of decompression illness, 3 options: to stop diving or to dive more conservatively or to have the PFO closed. So in this specific case, the decision-making was beyond the cardiologist and the neurologist. It needed to take into account the will of the patient to go back or not to go back diving. And this is already talked by Dr. Pedra. So we, based on the statement number 5, we asked our patient if she considered to stop diving, and she completely refused, ruled out this possibility. Neither to dive more conservatively was in her mind. So we decided to close the PFO. We thought it was the best management for these patients. So here the procedure I performed in January 2018. Here the guide were passing through the defect and the Occlutech 2325 device being positioned in the interatrial septum. The final aspect was well positioned. 5 months later, we performed a transesophageal echocardiogram that demonstrated no residual shunt, no bubbles passing from the right to the left side of the heart. So in that moment, the patient was free, and she was very anxious to do it, to go back diving. And she really went back diving almost immediately. She went back diving very deeply, up to 60 meters. And since then, she had already dived, performed around 52 dives, including Micronesia, without the appearance of any other symptoms of decompression sickness. So that's the case. That's not quite usual in our daily basis, and I really wanted to share with you. Thank you very much, Sheila, and the panel to participate of this event.
Thank you, Monica. Beautiful case.
Beautiful
Now, I would like to invite the moderators, Otávio Pontes Neto from Hospital das Clínicas de Ribeirão Preto, Gisele Sampaio Silva, also stroke neurologist from Einstein and Unifesp, and Raul Rossi, cardio interventionalist with a large experience in PFO, and to discuss this session. That is a great session. Thank you to all of speakers. So let's ask to the audience first. Let me see if I can send a question to the audience. Do you investigate PFO in patients with refractory migraine with aura? Let's answer. That is a very interesting discussion. Dr. Pedra talked about it. So 63% yes, 37% no. So I think the majority here are cardiologists. And do you think we should indicate closure of PFO in migraine patients with refractory aura? Let's vote. That's a very interesting discussion. So 71% no. Otávio, what do you think about migraine and PFO?
I think it's important to qualify the aura and also the circumstances that the crisis, the migraine appears, right? So there are more important information that you should get from the patient. So the fact that the patient get migraine with aura after, a long trip, or maybe being restrained in the bed for a while, or the fact that the patient get migraine with aura with complex symptoms, not only, visual aura, but maybe some sensorial sensitive aura, more complex aura. That's some things that may drive me to, to be more prone to more aggressive to investigate a PFO in these cases. I've never sent a patient to close a PFO with a migraine with aura. I have migraine with aura myself. I should probably perform a bubble, transesophageal, or maybe, a transcranial Doppler with the bubble test. But I think that, in selected cases, in this case, and I think we all are aware of this economic class syndrome, right? when somebody goes from Brazil to to Europe or to US and travel in economic class for like half a day. You can't even move for a while. That is something that has already been described as a precipitant for a stroke. And that is something that also would, you would keep me on alert if the patient developed a migraine with aura just after some kind of, these conditions. But I think that we still have a lot of work to do in terms of investigate and select which kind of these patients would be indication for treatment, right? And we really have to individualize treatment. I also have one question related to the fact that I really believe that some of the patients that we see in the clinical practice, we do not investigate much this predisposition to develop embolic stroke, paradoxical embolism, right? And I think how often do you guys evaluate this kind of behavior for those patients? This is something that we should look very carefully in this kind of patient with cryptogenic stroke, and the history of travel and the history of immobility. This is something very important to search in this kind of patient, I believe.
Are you asking to the cardiologist?
Yeah, I would like to know to the panel, to Luciano.
What do you think about the Otavio's question about to investigate the?
So you mean among stroke patients or migraine patients?
Cryptogenic stroke patients.
Yeah. So as a policy here, we investigate people who have who are younger than 16. And we only do bubble studies for those who are older, but have a clinical situation that may have led to a stroke caused by a PFO. So yeah, because we can't do bubbles for everyone, and we have to take care of the resources. Going back to migraines, there are several studies showing that migraines can be precipitated by microemboli coming from the heart, right? So they can cause cortical spreading depression, and if you look at the RX study, they found a correlation between embolic strokes and migraines.
Right.
So and then we wrote an editorial based on basic science papers which have really demonstrated cortical spreading depression caused by microemboli. Does that mean that we should close PFO? Right. My answer at this point would be no.
Exactly.
Based on those small trials and based on analysis of the clinical trials for PFO closure in patients with strokes, which they did look at migraines, even if it was not the primary endpoint, and then didn't find any differences, right? Any benefit.
Right. I also maybe how want to comment.
Yeah.
Can I just say something? But
yes.
I think we are talking about two different animals here. The guy who has the migraine and aura is different from by all my modesty, from the guy who has migraine with aura and had a stroke.
Oh yes.
Yeah.
Oh, yes. Completely different.
If you look backwards and see how many patients had a stroke, PFO associated stroke, and improved their migraine attacks or cured the migraine, the incidence is very high. The greatest thanks I've ever received from those patients were from patients that I treated PFO after a stroke, and they said, "Doctor, I didn't have a migraine anymore. Since I was a kid, I had migraine." So I think one thing is lacking is to study properly. We have to design trials, better trials, to look into these patients.
Right.
There is only another thing I would like to talk about: atrial fibrillation. Atrial fibrillation. So, we close the PFO, patient have atrial fibrillation, have to use anticoagulants, which is really a pain. Well, the great majority of atrial fibrillations after PFO closure occur in the cath lab or just after. And those patients, once you treat them with anticoagulants and you revert the sinus rhythm, 3 months later, they cure, you don't have FA anymore. Because the device has some inflammatory response. So I think the biggest problem is if you miss episodes of atrial fibrillation, send the patients to PFO closure. And I think the jury is still open, how is the best way to look into those patients and to investigate them, because probably the best thing to do in the patients after 60, not younger than that, is to put an implantable device, which is expensive and is not an option in Brazil.
Yeah,
and
that makes a lot of sense.
That's it.
I agree with you. We should scrutinize for AFib in those patients that we are sending to closure, mostly after 50 years old or 60. I have one question for you guys regarding the sensitivity and specificity of transesophageal versus TCD. One thing that I find frequently is that the fact that the patient sometimes does not cooperate, a stroke patient, sometimes does not cooperate very much with the Valsalva maneuver during the transesophageal echocardiogram. And we have seen some cases that the patient they didn't found the PFO with a transesophageal. We do a TCD, and there's a lot of, when the patient really cooperates with the Valsalva maneuver, we see there's some shunt. In some cases, you come back to the transesophageal, then you found the PFO is not a pulmonary fistula or something like this. So did you see this in your practice as well?
Can I answer that?
Yes, absolutely. Yes.
Well, I think that TEE is a great tool for showing the PFO. Right. Secondly, in ambulatory TEE, you inject bubbles from above. And sometimes you have a small shunt, the patient has stroke, the echocardiography say, well, it's a big PFO, but the conductance is not very big. When you go down, you go to the cath lab and inject bubbles from below, they just slip through to the left atrium. And I think the TCD is a great tool for those patients, but TOE is very nice for anatomical point of view, for anatomical instances, but not for, there are a lot of pitfalls in this situation as well.
Right, makes sense.
One other benefit for TCD, I think, is to control residual shunts at 6-month follow-up, as we usually did transesophageal echocardiogram, and I think maybe it's as sensitive as transesophageal, and you can put the device in a transthoracic, so the TCD has these benefits to be more comfortable for the patient and as good as enough.
Perfect. A very important question.
Luciano wants to comment, I guess.
I didn't want to interrupt, but sorry, Sheikh.
No.
And this is a related question, and might be for you, Carlos, and the other cardiologists. We have done around 150 procedures or a little bit more in the last 5 years. And 2 of them were found to have a PFO in the TEE, but when they went to close it, it was not there. They couldn't do it. Have you found anything like this in your practice?
Oh yeah, for sure. Sometimes TEE, well, in my perspective, that should be performed beforehand. Those patients can be deceiving. You might see something that looks like a PFO, and there is a little bit of flow between the lamina of the fossa valis and the septum secundum, but if you go there, there's no passage of anything. because it's sealed, right? It's a PFO. In fact, it's a gap between a trap door, right? And if it's closed, it's closed. And sometimes you engage your catheter there, and you try very hard to pass through the PFO, and there's nothing. And it's a problem. I've seen people going to jury because of that, because of unnecessary kind of procedure, and that's bad for the echocardiographer who did the exam beforehand. But it does happen, and I don't think it's malpractice, misdiagnosis. It's just because sometimes it's difficult to see if the PFO is patent or not. So I agree. Sometimes we bump into those situations, and the only way is to try to cross in the cath lab with a catheter, and you inject. You are sort of in that gap, and you inject, and there's nothing there. There's really nothing.
But that's another advantage of the transcranial Doppler. I've learned it in Italy when I did my fellowship 10 years ago, and we usually perform transcranial Doppler electively before the procedure, during the transthoracic echocardiogram that we performed the day before, during the patient has been admitted in the hospital. So we perform a transthoracic, we inject bubbles, and we perform a transcranial. And the few 2-3 patients with the negative test were patients that during the procedure we do not find the defect. So it's quite interesting.
May I have a question here to Luciano? Because I think it's an important issue how to deal with those, how to manage those patients after closure. Usually we do like TTE, transthoracic, just to make sure that the device is in place after a month, 6 months, and 12 months. And then we do a TCD after a year. We usually give the patient more time for endothelialization and to make sure that the PFO is sealed. And usually if the patient can cope with meds, we keep them on aspirin for at least 5 years. These are the recommendations of these European papers. And if it's possible, for maybe a lifetime. And how does Luciano manage those patients? And if you have a residual shunt after a year, how do you screen those patients? Because this is kind of challenging for us as interventional cardiologists. How do you deal with that? Because probably you have a very good relationship with your interventionalists and to manage those patients.
Yes. We have a great relationship with the cardiologists. They're very nice guys, and we really work together. So we load them with aspirin and clopidogrel 5 or 7 days before the procedure. We do the procedure, and on the next morning, on the following morning, we do a TTE without bubbles. I say we, but it's not me, it's them, right? And then they examine them, and they are discharged home. They can't do any kind of physical activity for 2 weeks. They remain on aspirin and Plavix for 3 months, and then they stay on aspirin for the time being. During the first 6 months, they can't get any procedures unless they are an urgent surgery or something like that. If they require something interventional, they receive antibiotics. And then they are checked at 6 months with another TTE without bubbles, and then at 1 year, and then at 2 years. But we don't really do any transcranial Dopplers or bubbles. And I personally investigate them with at least 14 days of Holter after the procedure to look for AFib. And so far I haven't had any. I only had 2 cases in very young people who were treated with apixaban for 3 months. Then we stopped it, and they remained on the aspirin.
That's great.
And what the reason why you don't do the bubbles for the follow-up?
Very honestly, I don't know.
I would say, you know, maybe a 6-month a TCD with bubbles.
Yeah.
Yeah.
You know, just to check on the right.
We have only found a couple of cases of residual shunts, but we may be underdiagnosing them, and we haven't done anything with that. We just leave them with the residual shunt.
Okay. And you leave it with aspirin, probably, right?
Yeah, and you know, if it's a, you know, residual shunts are associated with a higher risk of recurrence, and that's something relatively new. We didn't know that came from an observational study that was published, I think, in Annals of Internal Medicine. But before that, we thought that if there was a residual shunt, it was so small that it would not cause a stroke. But now we know that it seems to be a risk factor.
Yeah, well, regarding residual shunts, there are many types of residual shunts. Sometimes the device doesn't oppose properly to the septum, and then you have a tunnel through it. Sometimes you have a second ASD, a smaller one, especially in large aneurysms. And sometimes the device itself lose the grip of the secundum septum and goes into the tunnel. That's the most difficult type to re-intervene. But we all understand that if you have a residual shunt, that's maybe bad news.
Guys, I have a tough question for you guys for the cardiology. How probable would you say that this kind of intervention would be ever incorporated into the public healthcare system in Brazil?
Yeah, exactly. Yeah, because this is a challenging situation. Because you think the PFO is the culprit of stroke, you cannot close it because exactly. It's not paid by the public health system in Brazil. So
Kaka is laughing there. Smiling.
Yeah.
Let me tell you a story.
Yeah.
I started in 2009 to the process to introduce the ASD closure in the Ministry of Health. Last year, after 2 very long studies, one carried out by Kaka, the Ministry of Health allowed to close ASDs in children.
Yeah, we know that. Yeah,
I know. Yeah.
So probably PFOs, maybe my kid, if he wants into cardiology, he will be doing that in 40 years.
Unfortunately, there's a problem here. I think that if the Ministry of Health approves the use of those devices for PFO closure, there will be an abuse of.
Yes. I can understand that. Yeah.
Very, very reluctant to approve, and I fully understand that. And from the administration standpoint, if I were the administrator, I would agree. And that's because, in some places, unfortunately, there is misindication. So, that's how life is. But I agree that some patients can benefit from this procedure. As we saw, we were all on the same page here in all those presentations, and I don't think they're gonna approve, unfortunately.
Yeah. In these patients, what do you think we should do?
That's my next question.
Yeah, the next question. I already vote here. Anticoagulation or aspirin for those patients that you cannot close the PFO.
Let me just break it down more, Sheila. Would you go for anticoagulation with warfarin, anticoagulation with a DOAC, And which one? And anticoagulant and aspirin or in antiplatelet agent.
Let me see all of you. Luciano, first you. If you cannot close your PFO and you think the PFO is the culprit of this stroke, what do you do?
Whatever I'm gonna say doesn't have any. I have to disclose that, but I would probably use a DOAC,
right?
Because it's easier, and we have also thought about using DOACs to bridge between the stroke and the closure.
Yeah.
But sometimes it takes 2-3 months before we get it closed, and that's another possible indication, right? But I would probably lean towards a DOAC.
Right.
Perfect. And the cardiologist, Dr. Pedra?
Well, at Dante Pazanese, we have a very large volume of SUS patients, right? The Unified Health System in Brazil. We keep them on aspirin. It's very, it's
300 or 100? 100.
100, yeah.
Okay.
That I learned with my hematologist.
Yes, it doesn't make difference.
So they have antiphospholipid antibody, and he says that 100 is enough for proper anti-aggregation. So I think it's cheap. There's a very high adhesion to the treatment, and I think it's an okay option. And one of the problems of the trials, and as cardiologists, we thought that aspirin didn't work, and that's very wrong. It does work, right? It does work. This is why it was so hard to show a superiority of the device over antiplatelets. It took a long time, lots of patients.
Right.
We say the NNT is not, great.
Mm-hmm.
Sometimes you have to treat like 40 patients to see effectiveness. And I personally, I believe that those thrombi are white thrombi. They're platelet thrombi. They're not red. It's totally different from atrial fibrillation. That's why patients with PFO-associated stroke, they have a more benign course, usually, not always, but usually, right? So, and that's why aspirin works. So that's what we do at Dante Pazanese.
Guys, but let me ask you a question. So instead of this binary, question, either one or the other, would you say that, in some situations you would switch from aspirin to a NOAC?
Yes.
If the patient, for instance, goes to a trip, to economic class trip, or would you think about it? Would you consider switching for?
I'm not sure about Luciano. I think there might be one indication that anticoagulants might be superior to aspirin when you have aneurysm of the intra-atrial septum. Because some authors advocate that thrombi might be formed within the septum itself, not coming from the inferior limbs. So I think when if you take a look at ad hoc sub-analysis of those trials, anticoagulants might be superior in those patients. So I would shift, but I don't think, this is crazy. If the guy goes, for a long trip, you give, like elixir or whatever, it doesn't make sense to me.
Actually,
people do that, maybe treating their conscience or whatever. I don't know.
Yeah, well, actually, we are rolling with the punches here because we know what to do. We have to close the PFO.
But we have to do this every day.
This is the real practice.
I usually indicate anticoagulation. I use anticoagulation in those patients that we cannot close. But
that is, I use it. It's not a recipe for many patients, but some patients can be advised to try to get some convenio, some way
insurance,
private insurance, and I know high rate, the highest rate of recurrences after the second year. And in this country, the second year is the 2 years is the time for to get insured and pay for it, and 2 years later you can get possibility of closure. So that's a point as well.
Wow.
Let me ask you a question to Otávio, Luciano, and Sheila, because we don't have data on the effectiveness of new oral anticoagulants in those patients. We do have on preventing stroke on atrial fib patients. That's a different animal, but not for PFO patients. Where's the data? Why do you use new anticoagulants for those patients? Because this is expensive. This is very expensive. And industry, they make a big fuss of those new anticoagulants, and they are not as good as we think they are.
So let me tell you. So just I wanna hear Luciano. He's the expert on the evidence now. But I just want to comment. You raise a very good point, Carlos. In most of the cases here in our public healthcare system, in the Hospital das Clínicas Ribeirão Preto, we give aspirin to the patient. We give the aspirin to the patient. But in selected cases, with high, those that recur, and that sometimes you find a patient that have two or three embolic strokes, and sometimes the patient recur with aspirin. So in selected cases, I'm switching to when the patient can buy, I'm switching to, in selected cases, to NOACs, and the evidence is poor, but it comes from a subgroup of analysis of, for instance, the Navigate-ESUS trials. The Navigate-ESUS trial, there's a subgroup of patients that use rivaroxaban, and the subgroup that had a PFO had benefit using rivaroxaban compared to aspirin. So we have, it's a subgroup analysis, so it's not we cannot really rely on, because the power of the sample size was not designed to answer that question, and the integrity of the randomization is not adequate for this subgroup analysis. Was not a pre-planned analysis as well. But so the point is I want to raise is that we should not put all PFO patients and all cryptogenic stroke patients in the same bag. I think we should definitely try to scrutinize, and there are cases and cases. There are PFOs and PFOs, and also cryptogenic stroke and cryptogenic strokes. And for some of them, I think we might be in a point that we need to be more aggressive in terms of anticoagulation.
Yeah, Luciano can.
Yeah. So in that same paper, Octavio, there is a small meta-analysis showing that it was non-significant for ESUS, for Navigate, but it was significant for the other when the studies were put all together. So that's the strongest evidence that I know.
Yes, in the meta-analysis, right?
We do not have strong evidence suggesting. Another way of looking at the same problem is by thinking, was that patient on aspirin at the time of the stroke?
Exactly.
So if he was already on aspirin or clopidogrel or whatever, then it might be good to switch him to a NOAC or something.
Let me ask a question for the neurologist. We know there is a few cases of lacunar infarctions that could be related to emboli. That's a very doubt that I have. How can we identify those patients, and if there is a role to PFO closure for these patients?
Well, you're hitting the ball, guys. You're just putting a home run after home run here. So it's a very tough question. I would say that the proper definition of a lacunar stroke is an ever-changing challenge for us, right? You can define it clinically, but you can use an MRI given the topography of that. But sometimes even you have a perfect less than 2 millimeters DWI on the posterior internal capsule, and the patient had a AFib, and you anticoagulate that patient. So it's tough to really make a call of a lacunar stroke. It's easier when you have a lot of lacunar strokes, a lot of, leukorrhiosis, and a patient has microbleeds and has, the whole picture of small vessel disease. But for a single, in a young patient with a single lacunar stroke, I would never, put my two hands in the fire, and say, yeah, this is this lacunar stroke. I'm not gonna treat the PFO. And I think that's the case why we can never, in a randomized trial, in a big trial with 2,000 patients, it's really tough to really call a stroke, a lacunar stroke, other than the clinical trial definition, right? So you really have to individualize that patient. So that's why I think that's actually, this is the most magical thing about stroke etiology and secondary prevention, is that it's really tough to put everybody in the same place, right? And Carlos mentioned very well, and also Raul mentioned very well, the fact that it's tough. It was very tough to do trials and to prove that PFO works. Number one, because aspirin works. You're not hitting a drunk guy, right? But the other thing is that it's really tough to really select the right patient for interventions in stroke, because it's not like MI, it's not like myocardial infarction that will have a very homogeneous population with atherosclerosis of the coronary arteries. It's just like, it's a very heterogeneous disease, and we really have to pick the right patients to select and to do a trial, right? So that's the bottom line, I guess.
May I ask a question to the whole panel here, out of curiosity, because to be honest with you, I've never closed a PFO in a patient with migraine. Never. Okay. I have maybe 3 or 4 patients.
Happy to hear that.
We discussed the option, and I never closed. So what would be your guys' experience? I know Joca and Raul are great operators. And what about you guys in neurology? If you ever had a patient with, refractory migraine who underwent PFO closure and maybe got better?
I have closed 2 patients with severe migraine because the neurologist referred and insisted. It didn't work.
Yeah.
It didn't work.
Yeah. So can I comment on that question?
Absolutely.
So I have never sent anyone for closure, because there are lots of other options for patients with migraines that we know that work, right? So you can spend years treating patients with migraines until they get better.
With placebo, right?
Yeah,
right.
So, and the other question, in terms of lacunar strokes, there are 2 things that I would like to comment on. The first one is that there's no, and I said that in the talk, that there's no relationship between topography and the PFO as a cause of the stroke. The other one is that there might be pseudo lacunar strokes.
Yes, that's what I'm.
And I want to show you something here, if you don't mind. I'm sharing my screen.
Yeah.
I don't know if you can see that MRI here.
Yeah.
So that looks like a lacunar stroke, right?
By definition, yes.
But then if you look at a 3D, in a 3D fashion, you can see that stroke is much larger.
It's much larger, yeah.
Okay,
this may be I'm not seeing the whole picture, but maybe a anterior choroidal artery stroke.
Yeah, it's could be, but
could be.
It's close to the ventricle, as you can see here in the anterior part, and when you look at the size here, it's over 30 millimeters, right? Right. So it's good to look at the 3 planes when you look at the images. So that's not a lacunar stroke. That's a coma-shaped stroke, which sometimes it's caused by branch disease. Sometimes it's caused by embolic strokes.
Yeah, but Luciano, even if you have a patient with a small 2 millimeters that fit the first definition, you know, sometimes you just have embolic disease with very small embolic signs, and so it's tough. It's a tough call. You know,
Yeah.
it's easier when you have a lot of lacunar disease and you have a small vessel disease everywhere. Then it's easy to call a lacune stroke, right?
But how many times have we seen a little stroke in the thalamus and then another hit on the contralateral hemisphere in the cortex, right?
Yeah, exactly.
So that's why
I guess that using DWI really helps, yeah, because if we only use CT scan, and sometimes that small dot DWI, it makes your mind completely clear, yeah. You see on the other hemisphere sometimes in the posterior circulation, and then you decide, oh no, this is not a lacune.
Yeah, we have to evaluate case by cases. Because of this, you need the neurologist together to decide.
Yeah.
Let me have this question to the neurologist, because, you know, throughout those years, I think I just had one neurologist coming to the cath lab to see the procedure, because, you know, my question is, how is the PFO closure procedure perceived by the neurologist? Because, you know, for a long time, I thought you guys had a sort misconception of these procedures.
Probably.
Very, very, very simple, I tell you. And not because I am an interventional cardiologist, it's very simple. And you guys like sometimes made a big fuss out of it. No, this is very risky, blah, 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 blah. And I was very happy to hear, you know, you in your first 3 questions that most of, you know, the audience indicated, you know, PFO closure. So how is the procedure perceived at this moment in the community? I mean,
Carlos, I think that you can be sure that we are not afraid of the procedure itself. We are afraid of closing a PFO that is not a PFO responsible for the stroke. That's what we are afraid of, not of the procedure. Yeah.
This is part of
and I have to tell Carlos that we have a very selected audience here.
Yeah.
You know, so folks here are with us the whole semester, and we've been discussing a lot. So they know your work. They know Luciano's work, and they've been in that. But I think you're right. I think there is some misconception as well about the risk of the procedure, and also maybe some misunderstanding about also the complications. And for instance, the fact that the atrial fibrillation is not that bad of an issue, usually temporary after the procedure. So I think your talks were very helpful, and Luciano's talks were wonderful.
Yeah, wonderful.
Because a lot of discussion, we need to increase the awareness about this among the neurologists. Yes.
Yeah, and for us as a stroke neurologists, we indicate the PFO closure without any problem. We have a lot of patients treated, but it's important to show to other neurologists and to other professionals that we can indicate, and the patient will be very well without complications. So for this is important, this meeting, and wonderful panel. Raul, do you want to talk something?
Just to conclude my participation here, I think I'm quoting Bernie Meyer, who works in Switzerland. In Bern. No, the primary prevention. No. I'm not crazy, but I mean, right. He had an editorial saying that closing PFOs is the best thing that interventionalists can offer to his patients, because it's easy to do, it resolves the problem, but it should be done in the patients who really need to be done. I mean, you have to have a strong team and a good relation between the interventionalist, the cardiologist, and the neurologist, mainly the neurologist, who is going to tell you, you have to close that one. And then you could do it, because for us it's a piece of cake. I mean, it's a no-brainer. but I think you have to choose, as Dr. Giselle said, choose the ideal patients in order to get the best of the results.
May I ask a provocative question? What do you do when you close the PFO and you go there and you follow up the patient with TCDs and there are still bubbles, going through the PFO that was closed? So Sheila, Otávio, also, do you change your, antithrombotic therapy? Do you keep like the patient on anticoagulation? What do you do when we still have, bubbles going on?
I asked for re-evaluation of interventionalist. We had a case and should be treated again, or but probably I will anticoagulate if you cannot treat again or correct the PFO. I will want to anticoagulate the patient.
I had one patient who Sheila knows very well.
Yeah.
A colleague of ours.
The only one.
My only big residual shunt patient had another stroke, and was a doctor. And
he was thrombolized twice. He had thrombolized twice, and he's perfect.
800 PFOs closed. That one had to be a doctor, right?
Yeah.
And then we closed it.
Positive CAM,
right. I closed it with a plug. No bubble study negative. After that.
Oh, perfect.
Yeah. Thank God.
Don't forget the hematologist. There is a lot of patients with borderline results that is very difficult to decide if they need to stay with anticoagulation.
Okay, guys, excellent point, João. Excellent point. Let me ask this in a whole panel question. To finish. Would you ask for a hematology consult, or would you test for venous thrombophilia in patients before doing a PFO closure?
Always.
That's actually.
I always think that there is this second hit theory. If you that 25 to 30% of the persons do have a PFO, why do some have a stroke? There is always something in there, I think, if you look for, but probably mild thrombophilia that you don't diagnose, and then, the patient has a PFO and maybe starts, anticonceptives, and then it happens.
Yeah, let me tell you this. We usually do here, but the problem is that if we discuss this with a hematology, you will jump like this and say that, they usually they are not using, performing a thrombophilia test in most of our cases because of the fact that they first ask for really the presence of history of unprovoked DVT or hereditary, the patients, they have familiar history of DVT, of unprovoked thrombosis, right? Because the fact that, the problem is that not all the thrombophilias are already known. There are a lot of thrombophilias that we cannot, we cannot call. There's no exam for them. And also the fact that some of the changes that we see and we find, sometimes you end up with a result that doesn't fit with the clinical picture of the patient, right? So I'm being a lot of questioning about it's really valuable. What's the value of performing all these thrombophilia tests in patients that we see with cryptogenic strokes? With PFO, right?
Luciano, what do you think, Luciano?
Yeah, we sometimes we don't formally consult the hematologist, but we do order a very basic hypercoagulable panel, because if someone is going to receive anticoagulants for the rest of their lives, then you can't close a PFO, right? Why would you close it? Would you close it and then on top of that give them anticoagulants?
Yeah.
I don't think there's huge evidence. I know this is controversial, and I see Carlos.
Yeah.
He wants to say.
I'm going to make a very provocative question, because in terms of primary prevention, can we identify, not now, but over time, patients with high-risk PFOs, and sometimes with, we don't know as yet, but I agree that these patients are thrombophilic patients, and we don't know their diseases, maybe because of their phenotypes, whatever, we're going to get there. Can we predict some patients with PFO that will have a stroke in the future?
Yeah, maybe you can use biomarkers, right? D-dimer, CRP, troponin.
This is a very interesting topic.
Yeah, wonderful one.
We should explore that for sure.
Because this is the holy grail, right?
The holy grail.
I have a PFO. So,
did you close it?
Take a look at those observational studies. There's no difference. But that's crazy. I mean, because you have, like you said, Otavio, you have to individualize. So if this patient had this biomarker, this kind of PFO, this kind of thrombogenic disease, Pumba, we should go and close the PFO in order to prevent a stroke primary in the future. I think this is the $1 million question.
Absolutely.
$1 billion question.
Yeah, because 30% of the people have PFO.
Exactly.
So if you start doing primary prevention, it's going to be really hard.
30% of people have PFO, but a very small number of them had a stroke. So there's something here we have to find, And a lot of people is thinking about it, but I mean, it will take a lot of time before that. I agree with Carlos.
Friends,
guys, we had a great discussion.
Great discussion. Thank you very much. Yeah, you can see all session now is available already. So thank you very much to all of you, and see you in the next Global Stroke Alliance. Bye-bye.
Bye-bye, guys. Thank you so much.
Thank you.
Absolutely.
Bye-bye.